Ready. Good morning, everyone, and welcome to our panel discussion. My name is Tamsin Booth. I'm Britain Business Editor for The Economist, and I'm your moderator for this session. First of all, I'd like to thank our sponsor, Centene Corporation. It's a company with a very interesting history. It's founded in 1984, first as a non-profit Medicaid plan by a former hospital bookkeeper, Elizabeth Bryn, who drew on her experiences in an orphanage in starting her organisation. It's obviously grown an awful lot since then. It's got revenues of about $80 billion and is very much for profit by now, but it's an interesting company. So our subject is the art and science of healthcare policy making. As you know, many countries around the world aspire to give their citizens affordable healthcare through universal systems. Meanwhile, in more developing countries, rising middle classes are putting the provision of healthcare right up the political priority list, just because big medical expenses are becoming a problem. For instance, to give you some stats on that, more than 800 million people around the world spend over a tenth of their household income on healthcare. Of those, 180 million spend over a quarter of their total household income. And what they're getting in return for that, the quality is often really quite bad. In rural clinics in China and India, for instance, only 25% of the diagnoses people are getting are actually even correct. And as poorer countries expand their health systems, rich ones are really struggling with affordability. New technologies, aging societies are pushing costs up relentlessly. In America, which of course does not provide universal health care, the rising cost of drugs and insurance is certainly going to be a big issue in this year's election. So the art and science of healthcare policy making is absolutely key. And I think it's safe to say that the science is going to be a lot more important than the art. So there is vast potential for digital technology, and in particular artificial intelligence, to give us the possibility of healthcare, cheaper healthcare at scale. So AI, of course, the hope is that it can reduce costs, waste, and improve diagnosis. And lots of people think that a digital health revolution is long overdue, even though that has been predicted for decades. With me to discuss all of this and much more, I have three panelists with us today. Sadly, Michael Nadorf, the CEO of Centene, is indisposed. We wish him a speedy recovery. Here to my left, we have Shubham Singhal, who is a senior partner and head of the global healthcare practice of McKinsey. We have Francesca Colombo, who is head of health at the OECD, and Peter Sands, who is executive director of the Global Fund for AIDS, TB, and malaria. So the first question I'd like to put is to Francesca, a very simple one, really, but an important one. How well prepared are OECD countries to fund future healthcare spending?
Yeah, sure. And the very short answer, if you want, is they're not prepared. They're not prepared, and the story is really quite clear, and you have highlighted it a little bit. Demands for care is going up. Prices of healthcare are going up. The cost of healthcare is going up. So in OECD countries, 9% of GDP is spent on healthcare. This is projected to be in the order of 11% of GDP moving forward in the future decades. What is important to know is that about 3/4 in the high-income countries, 3/4 of that spending is publicly funded. And if we look as a share of government spending, health already accounts for something like 16% of government spending. Projected into the future, if we look at the spending increase and the health spending increase, and we say, well, all of that will be funded by government spending, by crowding out, for example, other areas of government spending, that would mean that about 20% of government spending will be devoted to health. And so the issue is our governments prepare really for that? I mean, our governments prepare either to fund more of that spending increases, or to crowd out other areas of government spending? And the short answer is that no, they are not. So in a way, there is a need to look for alternative solutions as well. There might be solutions to obviously be much more efficient, solutions about better sharing of the health spending between the public and the private sector, so having a higher private spending on health as a share of total health spending. So the very, very short answer is no. There are actions which is needed. Not much is happening. There's a huge amount of waste in health system. We have done some work that pointed and estimated about 20% of health spending being ineffective at best, or in some cases even harmful for people. So that's a huge amount of waste which is happening in our health system that could be put to much better use.
Right, okay, thank you. Shubham, how can countries better organise to rein in costs while still improving care?
Yeah, it's a good question. I think there are three things that we need to recognize when we're looking at affordability as the question. First is we're not getting the right returns. So forget about, we focus a lot on cost of healthcare. For a minute, if you focus on the returns that you get, if you look at the last century, we received about 30% plus of GDP growth came as a result of improvements in health, improvement in public health, new treatments, and the like, which improved both lifespan, productive lifespan, productivity of the workforce. That, in more recent times, hasn't quite been there. In some of the developing countries, we still have improvement on public health, but if you look at the developed countries, we haven't had that. Now, we've been doing some research, and what we find is there's actually about a $15 trillion of GDP growth possible through known interventions in healthcare being better aligned. The challenge is, which is the second point, the health systems haven't reoriented to the fact that in most, at least high and middle income countries, the disease burden has moved to being one of chronic conditions and not so much infectious disease and workplace accidents and the like. And so, and the systems aren't designed for that. We still have a very hospital-oriented system, for example. And most of these interventions are actually around behavioral interventions, preventive and social. And so if you think about those, and if we were to reorient, 2/3 of the global, we estimate about 41% of global disease burden can be reduced. 2/3 of that by these interventions, which are not that expensive and are known, if you will. And then there's another part, which is obviously new medical advances that can deliver even more. So that's a big part of it. The final part of it is all of these systems, when I look across the world, none of them have been able to drive productivity growth. Now, service industries are hard with labor to drive productivity growth, but healthcare has shown none. Other service industries, financial services, et cetera, do show improvement. And you talked about the digital revolution. Even that, when we apply that, we add on technology. We don't improve the use and productivity of labor, for example, when we do that. And so there's a big opportunity to be able to do that.
Can I just ask, why is that? What is it about productivity in this sphere that is so hard to improve?
I think some amount of it is real, in that normally when innovation happens, you're willing to accept a certain error rate. I think it is hard to say a priori will design a system where we'll accept a certain error rate, despite the fact we have a lot of error in the system. So that's one part of it, which we can put aside. But a bigger part of it is the incentives are not there. Most systems are either government run, in which case it's budgeted through various political processes. And even in the US system is not really private in a meaningful way. And it's really not sufficient incentive in just the way that prices are set and the like to be doing material innovation, business model changes, to be able to take the risk, to reduce the cost in a meaningful way. And then regulations are rather strong appropriately, but they get in the way. I mean, even in the US, we regulate nurse staffing ratios as opposed to the outcome of quality. Well, obviously, when you regulate that, you can find a more productive way, but you can't take nurse staffing down, and so you will never gain that. So those are some of the challenges that exist, none of which intractable. It's known interventions.
Francesca, do you agree with that the involvement of government is very much behind low productivity?
Well, governments have obviously a fundamental role, particularly when we're talking about universal health coverage. The challenge of productivity, I don't think is just an issue for the government sector. It's an issue for the health sector as a whole, which is a very, very labor-intensive sector, and therefore, the prices, the salaries, the fees of doctors, nurses go faster than the improvement in productivity. So it's just, economists call it the Baumol effects. So there is something which is a little bit already difficult in the sector because of the very, very much labor intensity that you have. That said, there are opportunities for doing things differently, thinking, for example, about a more effective use of human resources. You mentioned nurses. Why not having a different skill mix in the health professionals with doctors doing the more complex type of activities and leaving the more routine type of routine work or even monitoring of people with chronic conditions to nurses. Now, it's very, very difficult to change that because the labor market, the health labor market, is incredibly rigid. Everything is rigid. The number of doctors and nurses is preset. What they can do, so the task is really very much regulated, and the health profession is very, very, very attentive that this is not changed. We set obviously fees. All of this, it's needed for achieving quality, of course, and concerns about ensuring that nobody is also left behind. But we have obviously the factory sector, which is incredibly rigid. And so some ways to find more flexibility, more agile solutions are fundamentally needed for improving productivity and addressing some of the cost pressures while maintaining quality, of course.
Thank you. Question for Peter. So clearly, in advanced economies, all sorts of concerns about the cost and quality of healthcare. Why should citizens care about addressing some of the very different healthcare needs of people in the developing world?
Before I answer that, can I just add
Absolutely.
some comments, because I thought this was a very interesting discussion, and just so that my current job obviously is focused on healthcare needs in the developing world. Prior to that, I spent a bunch of time as the lead non-exec for the UK's Department of Health, which oversees the NHS, and I've also done a bunch of work for the US National Academy of Medicine on drug pricing. Look, on the productivity side, it's not like there hasn't been marvelous innovation in the healthcare sector. There's been fantastic innovation, both in process and drugs and things like that, that have delivered benefits. However, I would say structurally, in most countries, the producing sector, including the doctors, including the hospitals, including the pharma companies, have been very good at capturing the benefits of those innovations, which is one reason it hasn't translated through to productivity. And the interesting thing about that is that appears to be the case whether you've got a private sector-led model or a public sector-led model. It is just the problem is that the healthcare sector is replete with market failure. There's all sorts of different aspects of market failure within it. And it's just really difficult from a policy point of view to overcome those failures in a way that doesn't lead to the producing sector actually capturing a lot of the gains from innovation. The other point, and I just want to build on your point about the problem is a lot of the innovation is actually in the areas of low marginal return, right? It's the newest oncology drug or whatever. The reality is we need the innovation in social care for older people. We need the innovation in prevention. And there, the returns are extremely high. It's just the structural incentives of the system are all about the tertiary sector, the diseases that rich people get, and so on. Now, where does this take me in terms of my current focus, which is dealing with AIDS, TB, and malaria in the poorest parts of the world? Well, there, the returns on innovation are incredibly high, I mean, a new diagnostic tool in TB would have, unbelievably high returns. Current returns on treating people with TB are sort of 40 to 1. Not a 40% return, but 40 times. And so very, very high returns. Now, why would people in the West, taxpayers in the West, be interested in investing in the health of people in the poorer parts of the world? Well, I'll start on a spectrum from kind of self-interested arguments to moral arguments. The self-interested arguments are, one is, if people are desperate and their children are dying and they are dying, you have unstable societies which are breeding grounds for terrorism, instability, and so on, and those problems will come and hit you if you live in Zurich or Davos or Washington or London or whatever, ultimately. So there's that argument. Second is a global health security argument, which is that if you create conditions in which infectious diseases flourish, you will get all sorts of nasty ones. We're seeing the coronavirus in China at the moment. There's Ebola, of course. Actually, the one people should pay attention to is multi-drug resistant TB, which is a very nasty, very threatening disease and is killing people in every single country in the world. If you don't deal with those in the places which are most vulnerable, they will come and get you in the places you live. So that's another self-interested argument. But the fundamental argument is a kind of look yourself in the mirror argument about a moral argument, which is we absolutely in the world have the tools to get rid of TB. Yet we allow millions of people to die of TB. Are we comfortable with that? We absolutely have the ability to deal with malaria. Yet the best part of 500,000 children are dying of malaria every year. And we actually spend very small amounts of money in the scheme of the world on fighting malaria. There's nearly 1,000 adolescent girls and young women who are being infected with HIV every day. If you think about this in return, think about the cost benefit of stopping a 16-year-old girl getting infected with HIV versus putting that person on antiretroviral treatment for the rest of their lives. And that's if they get antiretroviral treatment. It's an extraordinary return on investment if you can stop them getting HIV. So I think there are hugely compelling arguments for why we should be investing in the health of the poorest and most vulnerable in the world.
Thank you, that's very compelling. Francesca, with rising costs, how realistic is universal healthcare in future? And how do you think private provision and involvement is only going to rise?
So I guess provision, there's a difference between the provision of services, of course, where you can have private hospitals, private, self-employed professionals, and the financing. So universal health coverage is a huge achievement, and I think it's something that no country wants, if they have it, to let it go, and if they don't have it, they obviously want to strive to achieve it. So it's something which guarantees that all those who have needs have access to care and so forth, provided obviously you have good quality services. So in a way, if you just have access to services, but the services are not delivering quality, then you don't get sustainable and universal health coverage that make a difference to people. Now, the question is, and it's particularly important in high-income countries, with this cost pressure going up, is the model of universal health coverage still a sustainable one? And my answer is that yes, it is. But it does not mean that you don't need to do reform or address the cost drivers or address the waste that you have in the system. And in a way, think of doing things in a very different way from what has been done in the past. Something has already been mentioned. I mean, the health system of high-income countries have been created very much with a disease model, which is very much acute care-centric, hospital care-centric, which spends only 3% of total health spending on prevention, knowing that with aging society, with chronic conditions, the most cost-effective way of dealing with it is prevention. So only 3% of all the budgets. And we have systems which are geared towards the episodic needs of an individuals rather than continuity of care for patients which have chronic conditions, and therefore they're not going to die from one day to the next. They will be a client of the health system for a very long time. So I guess the issues is really to rethink about universal health coverage in a way that shift and address very much the way services are delivered, to be much more about anticipation, preventions, primary health care, and much less about the hospital care. But even to think about what do we cover and what do we not cover. So what's, in a way, the type of benefits and services that we want the public health system with the solidarity, with the pooling of resources to be addressing, and what perhaps there might be things that are left to private individuals to pay for themselves. And that type of discussion is very difficult to do because everybody just wants more and more and more. So we keep on adding to the benefits list, but we never really put into consideration whether something should be perhaps left to private individuals and private financing. These are very tough questions because individuals are obviously attached to a model of universal health coverage, and we're all attached to it. The reality, however, is one of system under pressure, and how do we make sure that we maintain those tremendous achievements of universal health coverage, but in a way that is sustainable in the longer run.
Absolutely, thank you. Shubham, could you tell us about just how much scope is there from digital technology to make big changes, AI, machine learning? As I said at the outset, there's been a lot of prediction that we're kind of entering an era of disruption in healthcare, but it hasn't really arrived. I think sort of this is down to those kind of producer interests, complex regulation, a fragmented market in many countries. Do you think that now is the time we're going to see it, and how will it unfold?
It's a good question. Let me just add one thing to what Francesca said. The notion of universal health coverage, moving from one which is this person covered or that person not covered, to saying everybody's covered, but what are the services that may or may not be covered, is a very important one. And it's important, one, for the sustainability argument, but one of the things we've seen is when you take things that are directly paid for by the consumer, obviously they have to be small and affordable for them to be able to do so. Not only do you remove that from the budget, but you actually create competition in the market. So for example, if you take LASIK eye surgery, it uses the same. It's a medical procedure. It's mostly not covered. And what we've seen over time is quality has gone up, cost has gone down, what we expect in other productive sectors to happen, which normally doesn't happen in healthcare. We've seen that there. Interestingly, as a lot of first dollar coverage in the United States was taken off with the higher deductibles and the like, Walmart now has a $40 primary care visit, which is unheard of. I mean, nobody else was able to kind of think about. They're creating a whole, in Bentonville, in a warehouse, they've created a model health system where they're just taking cost out. Now, that's an interesting part, because what they look at is that, look, it's not intermediated. I'm not depending on the government to pay. I'm not depending on a third-party pay. But consumers will make the choice to go there because the quality is there, it's convenient, and it's got the price point, and we'll get volume in doing that. So I think there's something interesting in that model of universal health coverage, if done right, can protect patients and create competition and innovation. That brings it to the AI and technology part of it. There's immense opportunity. There's immense opportunity if we think about different sites of care. So take just the chronic disease aspect that we're talking about. Obviously, the person needs continuous care. They need self-enabled care, more so than just go to a doctor, for even if it's 4 times a year or 6 times or every month. I mean, those are expensive and not sufficient, because what they need, a diabetic needs, is on a daily basis that they're eating right, that they are, have the right house and environment if they're old and infirm, that food is made available at the right times, etc. So that technology can make a big difference around the patient in being able to enable their community of caregivers to really be able to take care of them in a continuous self-enabled kind of way. Furthermore, if you just think about it, already we're beginning to have this, whether the artificial pancreas, for example, again, connected ability to monitor a person's glucose and change the dosage of insulin. So we don't even have to worry about whether they took that at the right time or not, right? Early days yet, but those are the sorts of things where when we apply, and we don't have to have big applications of AI, those kinds of things can really kind of move the needle. And so I can go on in a lot of different areas. The real question that it comes down to is oftentimes people say, well, consumers won't accept X or Y. I don't buy that. We accept that in many walks of life. When it's intuitive, it's personalized, people accept it. The real question is, as Peter was saying, is whether the establishment in the industry will accept it, because it obviously changes quite dramatically what they do. Being a caregiver where you have to, even simple things like lose control over your scheduling because someone else can schedule through an app, is highly troubling to most doctors to be able to let go. Let alone that, these people may not need as many visits because, care can just happen along the way. So I think that's going to be a big part of it. And again, the role of policymakers and how do we encourage that to happen is going to be important. I'd say we're beginning to see movement. Until recently, even places like the US in telemedicine, Medicare hadn't fully accepted paying for it. And even though when they started, they said it must only be provided through a clinical site at a doctor's office, so that you have to go there. It's like, it makes no sense. Why would we construct it in that way? And so there is the whole policy framework will need to exist to be able to enable that to happen. And I think those will be the two biggest things, is can we drive change amongst the medical practitioners, and then the policymakers can encourage movement towards it.
Peter, same question to you. Do you think we are now on the verge of a digital revolution, targeted, personalized medicine, AI, data analytics, all of that stuff, or do you think the producer interests will slow that down as they have done? I mean, the other problem, of course, is that these technologies have always raised the cost. I mean, technology has always raised the cost of healthcare in the past. At first, they're very, very expensive.
Well, to start with, on the sort of data technologies, I think there is massive opportunity to deliver better and more targeted care. Absolutely, there is. And we have tons of examples in our world where if we had better data, we could do a better job. Now, there are a few issues around that, though. One is very legitimate concerns about privacy. And sometimes we meet people saying, well, given the urgency of the needs in the places that we're operating in, shouldn't you worry a little less about that? And I'm saying, hang on, if you're men who have sex with men, or you are people who inject drugs, or you're transgender in some of these countries, you don't care less about that, you care much more about that, because the consequences of having your privacy compromised are pretty serious. So I don't think we can compromise on that at all. But we do need the tools. And increasingly, I'm of the view that, in a sense, we should be thinking about them in the same way that we thought about pharmaceutical drugs earlier in the history of these epidemics. So there was a stage where antiretroviral medicine for HIV was available in the West, but it wasn't available in the places where most people were dying. There was a huge amount of political, activist, industry work on that massively expanded access to antiretrovirals, and we've gone from, in 2000, they cost like $10,000 per person per year, to now we're doing it across a massive scale at about $80 a person per year. Now, that was all about saying, actually, it's unacceptable to have a life-saving technology that we don't use for the people who are at most risk. Now, we haven't had that same argument about life-saving data analytical technologies and saying, hang on, we've got those life-saving technologies, we're not using them in the poorest parts of the world. Shouldn't we be having that same discussion about how we deploy those technologies effectively to save people's lives?
Thank you. I'd love to invite some questions from the audience. If you just raise your hand and introduce yourselves, that would be fantastic. Thank you. Shubham, I think that you might like to take on the value-based point.
So value-based care has huge potential for obvious reasons, because obviously as we move to a world of chronic conditions, we have to manage the person across the various conditions over long periods of time, as opposed to we fix it and you leave. I would say we are at the stage where we're seeing and understand things that work. So we understand care pathways that are needed for a variety of conditions. We're seeing where models have emerged that are working, in particular at those that have some of the highest disease burden, the polychronic, multiple chronic conditions. It really is because we can wrap a set of services around them and really kind of provide intensive care, and those really are working. I think we're seeing unevenness around the world on the inclusion of social care, which for those populations is quite crucial, and that makes a big difference when you have those. What we have begun to see but not seen enough of is the application of value-based care to those that have less of a disease burden. So even what we're talking about in the world of prevention, the use of data analytics technology to be able to really understand how we would prevent someone from getting ill. So for example, I'll give you a very simple example. We've looked at this where an otherwise healthy senior had their spouse pass away. And it's almost predictable over the next 2 years, unmanaged, how the health is going to progress, because their normal social routines get broken. When they eat, when they go out, when they will go for a walk, when they, therefore get exercise, they obviously are depressed. And if you don't address what are social and behavioral factors, the physical health will decline. System isn't quite set up, and we're not at the point of saying value-based care is, so we figured out the value-based care from areas where it is intense physical health needs, if you will. We haven't quite been able to add on yet, and then not being able to do with the seemingly healthier population, and how do we think about that? But that's where the technology aspects really kind of will be quite important.
Peter, can technology help policy change faster? Second part of the question. Is it too slow at the moment?
Can I start with value-based care?
Absolutely.
I would say, look, value-based care only works if the buyer can say no and has a choice. Otherwise, it's simply an elegant way for the producer to capture more surplus. On policy, I think one needs to be clear about what one's talking about in policy. On things like treatment guidelines, there is no doubt that we need to move faster. I think technology can be an enabler, but I don't actually think that is the impediment. The impediment in a lot of these things is a mindset issue. One of the things I've been very struck, I come from the financial services industry, and in the financial services industry, you think all the time about the time value of money. You don't think in the global health community about the clock ticking of lives being lost. According, when WHO schedules a meeting to change treatment guidelines, the choice between doing it in February and doing it in May isn't informed by a sense of, well, if we do this in February, we'll probably save 10,000 more lives, right? It's informed by people scheduling in diaries and all this sort of stuff. The mindset isn't kind of in there. The other point I'd say about healthcare policy, though, is we have to accept that in our societies, healthcare is one of the most deeply political things there is. And therefore, the policy is going to be difficult and messy and complicated because it involves some very deep value judgments about your interdependence with the other people in your society. And also, anything around UHC is innately hugely redistributive. And a lot of what governments try and do is, who have UHC, is essentially dress things up through national insurance schemes and things like this, which are basically ways of achieving that without really people noticing how much redistribution there is. And one of the sources of resistance to any kind of UHC system is, frankly, the elites don't want to pay for it. So there's both a sort of technical side of policy, which should be sped up, but then the more political side, I think we have to recognize that it is innately and intrinsically political.
Shubham, would you give us some reflections on the political debate in the US at the moment? I mean, is it around, Obamacare, around Medicare for all? What kind of effect do you think that has on broader policy changes and addressing some of the problems of rising costs and waste and so on? Does it just sort of make everything much, much harder?
It's actually kind of interesting. The first thing I'd start with is while all the headlines are about what is different and people have differences of opinion, there's actually a number of things that there aren't a whole lot of differences of opinion that exist. So I think having no medical underwriting, essentially having guaranteed issue, regardless of your pre-existing conditions, is well understood. Nobody debates it, and there's no difference of opinion there. Having means testing on your healthcare costs is something that is well understood between the Medicaid program, the exchanges, et cetera, up to 400% of federal poverty limit that exists. So that part is clear. Understanding that value-based care is going to be quite crucial in the way incentives are set for the delivery side to be able to reorganize itself is also pretty well understood, and on a bipartisan basis, if we look at it, continues to advance. So the questions of division all come down to, one, what Peter raised, which is the nature and level of redistribution relative to what exists. Do you want to push that even higher? Two is the level of choice, or at least the Americans' perceived choice, as Peter was explaining to me earlier, which is, I may be rationed, but I'm rationed because I may not be able to afford something, as opposed to some bureaucrat said I couldn't have it. That is a real issue, and so that debate is just a viscerally held one by different people that continues. And the third one is the role of the private sector. There is a group that believes that if we were to simply eliminate the profits that exist in the private sector, that in itself would be a good thing. There is another side that believes, well, the government actually, if you look at any of these programs that they directly deliver, are highly inefficient in their delivery. In fact, less so than is the private. Just as an example, the debate continues in the Medicare, which is the program for the seniors. Medicare Advantage, which is privately administered, delivers the same A and B, which is the hospitalization physician benefits, at 90%. Well, that's a savings. Obviously, that comes with then you have some profits, you have some extra benefits, et cetera, that are provided back to the beneficiary. So that's a bit of the debate, where the points of debate are. And of course, there are strongly held views on that.
Yeah, thank you. Any more questions? The gentleman here at the...
And I get two simple questions. First of all, it's about the concept of waste. I share absolutely that idea. And my question is it probably easier to include waste policies about stop investing in certain ways and reinvesting that budgets in something very useful, such as promote health, educating children in healthy habits? That's one. And is it easier in countries such as the United States or Germany or Holland, rather than in those ones that we have a universal coverage, such as Britain, Portugal, or Spain, due to bureaucracy and the things we have? And the second one is probably much more complicated, and this is dedicated to all the economists in the room. Sometimes we think, we find from the medical perspective a lot of difficulties talking about our financial ministries and investors in health. Because healthcare and health, in a way, in diagnostic and treatment, is very well considered as an expense rather than an investment. And it is true that, as in any other investors, The financial public policies and the financial ministries in Britain or in Spain, what they want is they have the reimbursement or the return of their investment in just 1 year, which is obviously the health results we get through these investments take us a whole generation, maybe 1 decade or 2 decades. Is there any kind of tip to make those economists to understand that this is valuable and this is a good investment? Thank you so much.
Francesca, can you take that one on? Two questions there.
So the two questions, yes, sure. On the issues of waste, I don't think, again, it's an issue of whether you have a more public or private base of government waste. I mean, when we've looked at waste in health system, we find it in ways
Everywhere.
everywhere, no matter how you are organized. Obviously, there are certain systems, because of their organization, they might have more waste in the way there is uncoordinated care, and in others might be more waste in terms of medical errors which are preventable and so forth. I mean, waste is pervasive. It's about clinical waste, things which are repeated and should not be happening, unacceptable medical errors that could be prevented even using some of the medical technologies, variations in medical practice that is completely unwarranted. Depending on where you are, within even a country like Switzerland, you might receive certain services or not with level of volumes which differ significantly across the country in a way which is not justified by needs, administrative costs which are really quite high, issues in the operations, and you might have even the same type of inputs having very, very different prices within the same health system. So it's really quite pervasive, and it's regardless of how the system is financed and organized. So clearly there is an issue of addressing that, because if you don't address that, value-based healthcare is going to remain just a slogan. And fundamentally, you need to rethink health system by putting very much at the center the individuals and the persons. And so if you think, and it goes back to the questions of value-based healthcare, if you think what health systems are about improving the health of populations, and from a policymaking perspective, while reducing, obviously, the cost. And so that is really value-based healthcare, is how it's an approach for achieving that vision. And once you have that in mind, then you can think of all the different elements of it. One is tackling waste, the other one is using digital technologies in a much better way, and so forth, paying for results, and so forth. Now, on the issues of the investment, yes, you're right. Health, it's often seen as a cost. But I think there is, first of all, a difference between health systems versus health. And nobody would disagree that health is fundamental for improving productivity of individuals, for making sure that they can go to work and participate in the labor market, for pupils to be effective in schools, and so forth. I mean, there are lots of literature about the good value of health. The question is, the health systems and the spending on health system, does it all deliver that returns on investments? And that's where much more needs to be done, so that we can really get the benefits out of it. So it's absolutely fundamental to think of health as an investment, and obviously also health systems as an investment, but health systems do need to reform to be able really to deliver to the people and the individuals.
Thank you. Any more questions?
Can I just pick up on this? Because the reason I got involved in health, my background is in economics and finance, was because I was intrigued by as what I saw as an incredibly prevalent failure of communication between people with an economics and financial background and people with a clinical and scientific background. And if you think about your question, I mean, basically, most people from the medical world would say spending money on health is an investment. Most people in finance ministries would say spending money on health is current expenditure. And they sort of go past each other like this. And as Francesca says, actually spending money on health is both. And it doesn't mean that one is better, but we need to understand the dynamics of the two. So if I take HIV for a moment, if I'm spending money on antiretroviral treatment for people, that is current expenditure. It is essential current expenditure. The people will die if we don't do that, but we shouldn't kid ourselves that it's really an investment. However, if I spend money on protecting adolescents from getting infected with HIV, actually I can construct that as an investment because it has a very high return in terms of avoided future cost of antiretroviral treatment. So I think we need to be quite thoughtful on both sides of the about sort of disentangling the way to think about different sorts of expenditure. The other really powerful notion from economics that I think people in the medical world need to get more comfortable using is the notion of externalities. And the notion that, particularly say with infectious diseases, if I treat this one person, I'm actually protecting, or with vaccines, I'm actually protecting a whole lot of other people. And so the benefit to the society is greater than the benefit to the person. That is not true of all medical interventions. There are medical interventions where, frankly, the whole benefit is pretty well captured by the individual. And that means there is a different logic for how these things are paid for. There are also negative externalities with things like overuse of antibiotics and so on. But getting into that, I think, really helps people, can really help think about the nature of the payment models, the nature and the investment that should be happening, both in advanced economies and in the more developing world.
Thank you. The lady here on the...
Hello, I'm Divya Venkat. I'm the co-founder of a company building biomarkers for neurocognitive impairments. My question is around universal care. In your opinion, how far away are we from implementing universal care, if we were to think in terms of services starting with anticipation, prevention and primary care, as you highlighted? And what do you think the key barriers to implementing this is?
I'm sorry, do you mean universal care in particular countries or globally? Or
Globally.
Okay. Francesca, would you take that one on, please?
Yeah, sure. Though obviously I'm an expert more in high-income countries that do have universal
Sure.
health coverage. But if we look at the monitoring reports that the WHO have done, I think we are still quite some way. And what we see is that there are efforts in all countries to improve the access to the services, but the financial protections, which is a fundamental element also of universal health coverage, that is lagging behind. And so we see the countries in which individuals are getting a little bit richer, they want to have care, they want to have access, they end up buying for it out of their pockets. So they might have services, they might have access to services, they don't have universal health coverage, and fundamentally they're exposed to potential also catastrophic and impoverishing healthcare costs. So I think it's definitely movement is happening, which is quite good. There are situations which are improving in countries, but we're really very much behind delivering services to individuals and ensuring their financial protections. So in a way, obviously, those things need to go together also with a strong focus on the quality of the services, as I mentioned. I mean, very often I find that there is lots of emphasis on the financial protection side, for example, but not enough on the issues of delivering quality health services. And sometimes I hear that this is something which is only for the rich countries that can afford the quality. But very, very simple things, even about quality, are actually quite cheap. Even things about making sure that doctors wash their hands. I mean, that can be something which reduce infections and ensure quality of the services. So I think it's we see in terms of trends, it's really definitely people having more access to services, but the financial protection being an issue, and being clear about what you cover first. It's a fundamental one. Avoiding the mistakes of high-income countries. So in a way of skipping a generations of reforms that in high-income countries was very much geared towards the hospital sectors, and focusing first on the aspects of preventions, vaccinations, and so forth, issues in which you have high returns from the investment that you get.
Thank you. Gentleman here, please.
Frank Grossman, Alphen Healthcare from Zurich. I'm missing the point that patients are considered to be specialists, because we work with patients with rare diseases, and we talk about 400 million patients worldwide suffering, but only 5% has nowadays a treatment option available, even in Switzerland. So we can't talk about value-priced services and care because there is no care for those patients. Do you think, any of you on the stage, do you think that patients taking into actions and becoming a professional can be a big impact for the economic system of the healthcare? Because they save costs. We host an event in 3 weeks where we support patients talking to their doctors in order to save time, to get a better diagnostic, and to increase and empower patients while waiting for a treatment option which maybe is not available, will never become available, but still empower those patients or mummies and daddies, because 75% of rare diseases affect children, empower them in order to help them surviving and increase quality of life.
So empowered patients, is there a lot of scope there? Shubham, would you answer that one, please?
There absolutely is. I'm not an expert in rare diseases, so I can't comment on that part. But just there's absolutely, because a whole lot of care in a whole series of conditions that people have has to happen on a continuous or continual basis at least, that we do need the patients themselves or their family of caregivers to really be able to help be engaged in that. Preventive actions, the social actions and behavioral, all of those, the importance of those is very high, and those are best done in the person's normal walks of life. Around the family, could be around the place of employment as well if they are employed, but that is absolutely the case. Now, the part that we have to, this is where technology kind of comes in, if we can connect that with the community of the medical caregivers with technology, with access available, either in being able to have an interaction, whether it is asynchronous through email or otherwise, or directly through video, there's value to that. And it's also, there's value if we can monitor the patient's vitals, whatever those are, and then those be able to be transmitted to their primary care or what have you, so we can monitor. I think that would then kind of complete the loop, so we knew that if something was going awry that needed a greater intervention, that we could do that. And I think the technologies all exist. It's a matter of us bringing it together to make that sort of a system exist, and that would have enormous value.
Thank you very much.
Can I leap in on this?
Very,
I do
very
think
quickly, because we are running out of time.
I do think this is an absolutely critical point about agency, about the agency. And I struggle with the language of patients, because you want the agency of well people as well as when they're sick. And indeed, I have a problem actually with the UHC language. I think UHC is a means to an end, and the end is health and well-being for all. But the UHC is also something that is being done to people rather than people. And it's actually one of the underlying philosophies of the Global Fund, is that nothing gets done without the engagement and agency of the people who are being affected by the things that are being done. And to me, coming into this world, it's transformative. It completely changes the way you go about things if you have decision-making authority and influence, and real influence, from the people who are most affected.
Great, thank you. I'd like to thank our panelists very much for the input. We've covered an awful lot of material. For me, I think there were 3 points that came across really loud and clear that I didn't really know before. So first of all, the low productivity of healthcare, partly because of the weight of the medical establishment, the high marginal return that Peter talked about of preventing sort of contraction of disease in the developing world, a new whizzy oncology drug, and then just how political the subject is, because it's so redistributive, and how that impedes rapid change in policy. Again, thank you very much, and thank you for attending, and thank you for the great questions.